Mi kare ki a tātou, kia hora te marino, kia whakapapapaunamu te moana, hei huarahi mā tātou I te rangi nei, aroha atu, aroha mai, tātou I a tātou katoa, haumi e hui e taiki. Tēnā koutou katoa, he mihi mai aha kia koutou kua taimai nei ki te tautoko, te kaupapa o tēnei rā, nau mai ki tō mātou kōrero. Kia ora and welcome. I'm Moira Clooney. I'm the project lead for Te Ngako Kahukura, and really just such a pleasure to welcome you to this first of our series of webinar conversations around trans health in primary care. This webinar series has emerged from a conversation that's been really ongoing between Te Ngako Kahukura, Gender Minorities, Aotearoa, Professional Association for Transgender Health, Aotearoa, and Counting Ourselves, or the University of Waikato's Trans Health Research Lab, as well as all of our kind of colleagues in the wider healthcare space. And this conversation feels even more current right now. You might know that the government put some money into trans health and primary care in the budget a couple of weeks ago. There are details to be worked out about how that money is used, but we really hope that this series is a chance to talk about what this could look like, what's important when thinking about trans health in primary care. In the future, we want to see every primary care doctor feeling confident to work with trans people. So through this conversation over the three webinar sessions, we'll be thinking about questions like, how can we remove barriers for people wanting to access gender affirming care? What role does primary care play in providing access to gender affirming care? What do we mean by informed consent models of care? We'll go into that question in depth today. What do clinicians working in primary care, what do all of you need to know in order to provide competent general healthcare to trans and non-binary people, as well as to provide gender affirming care? So across all of our organisations, there's lots of agreement about how to answer those questions, and also some points of difference in terms of how the questions and how the answers get framed and understood, which really makes sense because we're all positioned slightly differently in terms of what we provide, what our backgrounds are, what our areas of expertise are, as well as our different kind of frameworks or paradigms of knowledge. And these webinars are really part of that ongoing conversation, which we are encouraging or inviting you to be part of. We don't anticipate that this session or the series will answer all your questions, but we're keen to point you to other relevant resources and places where you can find more information, and hoping to continue this conversation on in lots of different ways so that we can all together, I guess, take concrete steps towards improving education for people working in the healthcare sector and improving access to services for people who need them, as well as improving health outcomes for trans and non-binary people all over Aotearoa. So that's a bit of a spiel from me. I'll hand over to my colleague Joey to share a bit more about this particular session. Kia ora.
Kia ora koutou, kia ora Moira, thank you. Welcome to everybody who's joining us. We really are grateful, and we recognise this is a challenging time for anyone working in healthcare broadly or the health sector. So the fact that you're here and you're showing up to learn and participate in this conversation means a lot to us. This is, as Moira says, part of 3 different webinars as a series, and this particular one, we are really lucky to have Gender Minorities Aotearoa here, and Adeline in particular is going to be answering some questions after the presentation. We have Ahi Wihongi and Adeline also, working on the presentation together that we're going to show you in a minute. The main drilling down into the point of this webinar in particular is, what does informed consent mean in terms of gender affirming care? And informed consent gets used in a few different ways in lots of healthcare settings, so we wanted to be more specific about it. It's definitely a presentation that is aimed at prescribers and clinicians who work in primary care, but it's not exclusively only relevant to that audience. We really feel strongly that obviously for trans people, trans and non-binary people who might be seeking any kind of healthcare, it could be relevant, but it's also that we need people who are writing policy or designing health services, maybe who are part of the implementing of what the government has put in the budget for trans healthcare. To know how to champion better practice means you need to know what informed consent means in this particular space in terms of trans and non-binary health, and specifically gender affirming care. So you'll notice that the presentation is called Informed Consent in Primary Healthcare, and the webinar as a whole got framed as Trans People's Experience of Primary Care. We're not going to be going into, here's a whole lot of stories about trans people's experiences, although that is clearly in the background and framing of why we're talking about this. Really what we felt was important was trying to equip people to be able to use an informed consent approach, because that's what so many trans and non-binary people are saying that they need, you know, that they want their healthcare providers to be able to know how to do this. I'm really stoked that we have Gender Minorities Aotearoa here with us. And I think we often have a bit of a false dichotomy or a bit too harsh in our distinctions between what you think of as like community expertise and clinical expertise. GMA is an example of an organization that bridges those areas of knowledge. And I think we need to keep speaking into that space. So I really appreciate talking about things like self-determination and bodily autonomy, what that actually means in practice. And I think that the informed consent model and what you're about to see will be part of really pulling that out. You know, what does that actually mean you're going to do or say? That's quite relevant. I'll hand back to Moira to do practical kind of stuff, but also I didn't even say my name. So Joey McDonald, and my pronouns are in my little name there, they, them pronouns, and I'm part of Te Ngako Kahukura. We also have Jono, who's here doing tech support with us today in the chat. Yeah, but hand back to Moira for some practical webinar notes.
Kia ora, thank you, Joey. And yeah, just to cover off some of the practical side of things. So this is a Zoom webinar, which means that we can't see or hear any of you who are in the audience. We can see your names pop through. We welcome any questions or comments you have at any time in the chat function. If you share things in the chat, then we'll all be able to see them there. So feel free to say anything in there, introduce yourself if you'd like to, and add any questions at any time during the presentation. If you're asking questions, just be mindful, please don't give any identifying information about anyone. And you might not realize, I guess, in thinking about trans communities being quite small and interconnected, you might not think necessarily about how easily identifiable we can be. So if you are giving like a combination of location, age, and gender, any of those sorts of things can mean that people might know who you're talking about. So just as much as possible, please avoid giving details about specific people. Think about framing questions more broadly, even if it's a question that you have about your own practice and if you're thinking of somebody that you're working with. We're also not going to give any specific medical advice. This webinar is about professional development for people working in health services, particularly primary care. We also know the process of learning means that some people might ask questions in an awkward way. You might not be confident that you know exactly the right language to use. And we want you to know that that's okay. And to say to trans people in the audience who may or may not also be working in healthcare or also be clinicians, that we understand how difficult that can be, how unpleasant that can be sometimes. We will, if we're asking questions, if we're reading things out in the comments, we won't be repeating any offensive kind of content verbatim, and we'll try and reframe any questions that need reframing. Overall, we want to encourage learning by asking questions. So we want you to be really open and confident in terms of asking whatever you feel like you need more information on. Yeah, I think that's us for today. In terms of the practical notes, I'll hand back to Joey to introduce our speakers.
Cool, thanks. And if you get the video ready, I feel like because we've flagged that we have Adeline Gregg here with us from GMA to answer some questions after the presentation, and you're going to see Ahi Wihongi in the presentation giving us some content that is very relevant to all of the things that we're trying to frame up as the context for this information. Maybe I will just hand it over to the video, and that gives us a bit more time to have questions at the end. Yeah, sweet. All right. And please do put your questions in the chat.
Kia ora koutou. My name is Ahi Wihongi. I'm the National Coordinator at Gender Minorities Aotearoa, which is a national transgender public health organisation. I'm going to talk to you a little bit about informed consent in primary healthcare. So I'll just share my screen with you. Awesome. So informed consent in primary healthcare. In transgender healthcare, the informed consent model is where a trans person's right to consent to gender affirming medical treatment is presumed to exist. And it's contrasted to the diagnostic or gatekeeping model, where it's assumed that trans people can't give consent without having extra assessments. And those assessments are often in the form of psychological or sometimes psychosocial or mental health evaluations and screening. So the informed consent model of transgender care, an alternative to the diagnosis of gender dysphoria, tells us an alternative to the diagnostic model of transgender health is the informed consent model, which allows for clients who are transgender to access hormone treatments and surgical interventions without undergoing mental health evaluation or referral from a mental health specialist. The Australian Informed Consent Standards of Care for Gender Affirming Hormone Therapy from AusPath tells us gender affirming medicine is part of general medical care within the primary health care system, and a gender assessment with a psychiatrist is not required and is not mandatory prior to commencing medical gender affirmation. They also tell us that depression, anxiety, and suicidality are not contraindications to hormone therapy. In most cases, mental health can be exacerbated by denial or delay and improves following the initiation of gender affirming hormones. So if there's a reason to believe that a patient might not be capable of giving informed consent, then mental health professionals can be involved to help establish whether that's the case. But if there isn't a specific reason to presume that a trans patient is not competent to give informed consent, then they should be presumed competent to give informed consent. There's no need for routine psychological evaluations or assessments as a prerequisite. Most of the time, like generally outside of gender affirming healthcare, most medications are prescribed with implied informed consent and minimal documentation is used. So the majority of prescriptions don't require abbreviated informed consent forms to be signed, and they definitely don't require a psychological evaluation to be carried out. So in New Zealand, there are often sort of routine readiness assessments for trans patients, and doing that presumes that trans patients categorically do not have the ability to give informed consent and consent to their own healthcare. So that means that once a treatment is classified as being gender affirming, it becomes more difficult to access. The existence of a higher standard of informed consent for trans people's healthcare is discriminatory. It imposes extra testing and barriers that don't exist for other kinds of healthcare. So what we're going to do is take a quick look at why this kind of myth of psychological evaluations as prerequisite has become a common belief within the healthcare sector in New Zealand. In the early 1900s, when transsexual first became a diagnosis, patients had to meet really specific criteria in order to get diagnosed. Now, they had to be diagnosed so that they could receive gender affirming healthcare rather than electroconvulsive treatment or lobotomy, which were common treatments for trans people at the time. The diagnosis, the transsexual diagnosis, was based on the work of Dr. Harry Benjamin. He was the founder of WPATH, although he had not founded it yet at that point, but he went on to do that. So his theory was that trans women had a female brain and a male body, and patients had to prove that their brain was as female as possible through meeting stereotypes for women. Science has moved on, but our systems are still catching up. So, in modern times, best practice diagnostic criteria relies on a person's self-reported gender experience rather than having a professional approve the authenticity of their gender. Informed consent centers autonomy and a person's right to make informed decisions about their own body. But that old system of proving your gender through psychological evaluations, that there's still a bit of an ongoing, lingering legacy of that. So that's where that's come from. now we're going to just have a quick look at the legal framework. So the Health and Disability Commissioner is the person responsible for holding medical providers accountable to respecting the rights of healthcare consumers. The Health and Disability Commissioner Act tasks the Commissioner with creating a code of healthcare rights, which defines informed consent in New Zealand. Every healthcare provider is legally accountable to this code of consumer rights. Under the code, there are two really important rights related to informed consent, and those are right 6 and right 7. So I'm going to just quote directly from the code. Right 6, the right to be fully informed, meaning that healthcare providers have a legal obligation to give consumers a full and accurate account of all of their options for treatment and the expected timeframes for receiving these. And then right 7, so again, a direct quote. Right 7, the right to make an informed choice and give informed consent includes the right to be presumed competent unless there are reasonable grounds to presume a consumer is not competent. Without medical grounds to presume incompetency, consumers have the right, once fully informed, to make their own decisions regarding their treatment, their medications, dosages, and referrals. So that's quite powerful. So there's one type of situation in which the right to give informed consent is taken away and patients are required to undertake a psychiatric assessment. That can take place under the Mental Health Compulsory Assessment and Treatment Act 1992. So to quote the Medical Council of New Zealand, a person may lose the right to give informed consent and be required to undertake psychiatric assessment and treatment under the Mental Health Compulsory Assessment and Treatment Act 1992, unquote. So that's telling us that this type of situation where someone would be compelled to undergo psychiatric assessment is, it's quite specific. So it shouldn't be routinely, oh, you want to get hormones? Well, then you need to have a psychiatric assessment. If you're not invoking the Mental Health Compulsory Assessment and Treatment Act, then that shouldn't be happening. Cool. So now we've heard about what informed consent is and isn't, we're going to take a quick look at how it works. Planned Parenthood Great North West run gender clinics where trans people can go to start hormone treatment. In one appointment, the clinician and the patient discuss the treatment options and the potential contraindications and their goals for what they want to do with their healthcare. And they also carry out a blood test. Patient can leave the first session with a hormone prescription. So I'm going to quote Planned Parenthood, which is in the United States. They say, you don't need to participate in therapy or provide information from a mental health provider to receive hormone therapy. They also say, in most cases, your clinician will be able to prescribe hormones the same day as your first visit. No letter from a mental health provider is required. So that's often regarded as the gold standard of informed consent. So now I'm going to quote from the guidelines for gender affirming healthcare for gender diverse and transgender children, young people and adults in Aotearoa, New Zealand, which we're just going to call the New Zealand guidelines because it's a wee bit shorter. So they say, while many trans people access psychotherapy for support with living in their affirmed gender, psychotherapy is not a requirement of accessing gender affirming care. And they also say, in New Zealand, young people aged 16 years and older are considered to be able to consent to medical care under the Care of Children Act 2004. However, it's increasingly recognised that there may be compelling reasons to initiate hormones prior to the age of 16 years for some individuals. There's actually some interesting research coming out now about that. And there are some very compelling reasons to be initiating hormones prior, but I won't go into that. So the New Zealand guidelines provide support for an informed consent process. They give the information necessary for primary healthcare provider to diagnose, well, not that diagnosis is necessarily required, but to understand that a person is trans and to prescribe hormones and to provide ongoing maintenance care. Some informed consent standards, including the internationally recognised Callen-Lorde standards, don't use regular hormone maintenance testing. Instead, they rely on patient feedback. So they don't schedule in routine, ongoing checkups for hormone maintenance. They just rely on patient feedback. So that's a slight difference perhaps from the New Zealand guidelines, but but there's that. The New Zealand guidelines include forms for informed consent, which is sometimes called abbreviated informed consent, and those are in appendices C, D, E, and F, and they're a simple way to manage legal liability. So now we're going to touch on a checklist of what you might need to be aware of, or what you do need to be aware of when initiating gender-affirming hormone therapy. So we've created it's actually an 18-point checklist, which is somewhat based on the checklist by Transcare British Columbia. Their stuff is also, I mean, some of it is very good, so it's also worth having a look at. Not everything from international frameworks applies directly to New Zealand context, so that's why things often need a bit of tweaking. But so we're just going to run through our checklist now. So a lot of things on this checklist are actually just sort of the general things that you do with all patients, like general medical intake, medical history, family history, that sort of thing. Discuss the patient's gender, which is sometimes referred to as gender identity. We prefer to refer to it as gender because it's not just how you identify, it's who you are. It's just as legitimate as anyone else's gender. So discuss the patient's gender, discuss their gender-affirming healthcare goals, discuss the expected outcomes of hormone therapy. So this is about making sure that they have a, that they have a realistic understanding of how hormones will affect you. You need to carry out baseline blood work. New Zealand guidelines has some, has some in-depth, the specific blood work that needs to be carried out. Blood pressure, cardio, respiratory exams, things like that. This stuff is also covered in the New Zealand guidelines and in basically all of the quality guidelines from around the world. And review their relevant health records. That one can be a little bit tricky because sometimes if clinicians I've seen in the past haven't understood them being transgender, then there can have been a lot of messy stuff put into their medical records. Sometimes if someone is trans and the doctor doesn't understand that that's a real thing, then they think that person's got psychosis or all kinds of, there are a lot of diagnoses that trans people get that are incorrect. So it is important to understand that when you are reviewing someone's relevant health records. Next, you want to discuss the contraindications to hormone therapy. So that's hormone sensitive cancers and things like that. There are very few conditions that would be a hard no to going on hormone therapy. So so the main ones are hormone sensitive cancers. And as we've talked about before, things like mental health issues, they're not going to stop someone. They should not stop someone from being able to take hormones. Discuss treatment options and timeframes for receiving those different treatments. Make recommendations for treatment and discuss the options which the patient prefers. And then review the potential side effects of those specific treatments. You will need to discuss fertility implications of the specific treatments. This is one of the areas that there are also quite a few myths about within the healthcare sector. It's important that trans people understand that you cannot pick and choose which effects the hormones will have on you. So if you're really wanting to be able to get pregnant or be able to get somebody pregnant in the future, that may not be possible. It also completely may be possible. You're not guaranteed to become sterile, but you're also not guaranteed to not become sterile. So so it's important that that's represented accurately to them. Discuss risk mitigation, such as smoking cessation support, that sort of thing. And then finally, you want to assess the patient's capacity to consent for hormone treatments. So that's as simple as, have they demonstrated during your conversation with them that they have the intellectual capacity to understand and give consent. There are also, if there are reasons to believe that they don't have capacity to consent, then you might need to refer them on to mental health. Otherwise, in most cases, review and sign the consent forms with them, and then prescribe them hormone treatments and go over the, follow up. You might want to book them another appointment or talk about when they need to come back for, monitoring and maintenance if that's the way that you can carry that out. So there are some other things that you might want to discuss with your patients as appropriate. They're not needed prior to commencement of hormone treatment, but it's good to discuss if they want to. Discuss their support systems, their family, peers, work, school, that sort of thing. Discuss referrals if they're interested in being referred for other gender affirming treatments such as surgeries or mental health support or transgender advocacy and peer support services. Or if there are other things that they might want referral for, like voice therapy. There's lots of things. You can find medical and plain language guides to hormone therapy on our website at genderminorities.com. A lot of trans people find these quite useful, particularly because they are not written in medical language, so they're easy to understand for people who aren't who don't work in the healthcare sector as well. And there are a few other things to consider, which often or sometimes are not included in guidelines. So we're going to touch on a couple of those. So one central risk in prescribing hormones to trans people is that they'll be prescribed a really high level of hormone blockers without an adequate level of replacement sex hormones like testosterone or estrogen. Low levels of sex hormones or hypogonadism can result in anxiety, depression, fatigue, difficulty concentrating, low sex drive, hair loss, osteoporosis, hot flashes, and it's also associated with heart disease and other cardiovascular issues. So it's really important that sex hormone levels are high enough. And particularly for adults, it's not good for an adult body to not have enough sex hormones. So a really simple indication of whether their levels are high enough is how they feel. How does the patient feel? If they're experiencing anxiety, fatigue, and they can't concentrate and they're really depressed, you want to talk to them about those things and make sure that they are happy with their levels and that you don't think that their levels are too low, which is also something to remember with trans women who are of postmenopausal age. One common issue in New Zealand is that they can be put on a very, very low level of estrogen. But the issues for trans women are different from the issues for postmenopausal cis women, and who obviously are also not trying to change their body. If you want your body to be essentially going through puberty long term, then you need to have correct levels of hormones. So so there's lots of issues around that. Many trans patients are going to prefer to take a safer course of HRT or hormone therapy, where blockers are prescribed at a low level or are not prescribed at all, and sex hormones are prioritized. So for estrogen treatments, the Endocrine Society clinical practice guideline recommends 1 to 200 pg, which translates as 367 to 734 pmol. So pmol is the measurement that we use in New Zealand. Sometimes clinicians can get confused because some of the guidelines are talking about pg and some are talking about pmol, but it's 367 to 734 pmol. So the New Zealand guidelines recommend up to 500 pmol, which is 234 less than it's only 2/3 of what the Endocrine Society clinical practice guideline recommends. And it's quite low compared to a lot of international clinics. So, ask your patient for feedback, find out how they're feeling, and if they want their dose to be higher, then maybe put it up. The AusPath guidelines tell us recommended ranges should be used as a guide rather than a rule. So this means prescribing gender-affirming hormones based on how a patient responds to treatment and alongside risk factors, rather than based solely on specifically targeted levels. that's really solid advice. The patient's response should be measured in terms of their transition goals. Patients respond differently to different levels of hormones, so appropriate levels are going to depend on the individual's level of bodily change and also like a positive psychological response. And I guess last of all, I'm probably running over time a bit. Last of all, we're just going to touch on surgical referrals. There are so many things that I would love to talk to you about, but we're just going to touch really quickly on surgical referrals. So genital reconstruction surgeries are available through public healthcare in New Zealand through a pathway managed by the Ministry of Health. Referrals to this pathway are arranged between the Ministry of Health and DHBs, whereby DHB specialists make referrals, and this can include, like, specialists who can do referrals include endocrinologists, sexual health doctors, various other specialists. And in some cases, general practitioners are authorised to make those referrals as well, as approved by the DHB. So that's something that can be organised with the DHB so that doctors can do that. General practitioners can do that. Also, in the old days, before, in the previous system that we had, it was very, it wasn't very clear who could make referrals and who couldn't make referrals. So maybe this might change again with the new, with Health New Zealand and the changing of how the system is. So it'll be one to keep an eye on. Ideally, those referrals should be able to come from primary healthcare, and primary healthcare providers should be able to find out how those referrals work. Trans people should be able to go to their primary healthcare providers and get all the healthcare that they need and get all the referrals for anything that needs to go off to a specialist. It definitely should not be the responsibility of a transgender patient to find out how to get a surgical referral. So the surgical criteria for genital reconstruction referrals in New Zealand is based on the WPATH criteria, completely within a primary provider's ability to assess. And those factors are A, persistent, well-documented gender dysphoria; B, capacity to make fully informed decision and consent for treatment; C, age of 18 years or older; D, if significant medical or mental health concerns are present, they must be well controlled; E, 12 continuous months of hormone therapy as appropriate to the patient's gender goals, unless hormones are not clinically indicated for the individual, which we're going to talk more about in a minute. And F, 12 continuous months of living in a gender role that is congruent with their gender identity. We're also going to touch on that again. So that criteria is a bit outdated. It doesn't align well with informed consent. The WPATH criteria includes living in a gender role, which is a subjective judgment of gender expression, rather than being based on the patient's presumed competency to make informed choices. So we're kind of going back again to that stuff we touched on earlier, where that living in a gender role used to be, that's where WPATH came from. And things have been, it's of course gone through lots of iterative changes every time new standards of care comes out, but we are not quite there yet. So there's that, but that is the current criteria anyway. And while it's not explicit, in the criteria, when it says unless hormones are not clinically indicated, it means that hormones are not actually a requirement. They're not medically necessary. So if the hormone treatment isn't indicated by the patient's transition goals, like they want to have surgery but they don't want to have hormones, that's fine. That's absolutely within the criteria. So how to support your patient with referrals? Like the first thing is probably just understand the current criteria. It isn't perfect, but it's what we're working with right now. So so I guess also being understanding of that is good, because sometimes the patient's going to be upset about aspects of it, and sometimes that's really fair enough. So being understanding about that, understanding the current criteria. Talk about all of the options with your patients and ask them what they want. Then make referrals promptly. Ensure that the referrals prioritise and support your patient's ability to give informed consent, and provide detailed information to your patient throughout the process. Under the Privacy Act, referrals should contain only the necessary information required for that referral. So if the referral asks for all of the patient's medical records, which they don't, then fine, you could send all of the patient's medical records, but usually that's not what they're asking for. So just make sure that you really read what they want and only send the necessary information. You can find out what other treatments are available in your region using the 3D Health Pathways tool online. And that will also tell you which specialists can receive referrals. So it can show you the pathway through who needs to refer to whom to get the patient where they need to end up. You can also find out what each DHB offers and a wealth of other resources on our website at genderminorities.com. And if there's anything that you can't find or you need information, we are here to support not just your patient's journey, but yours as well. We care a lot about you guys having the information that you need and supporting you on that journey. So kia ora, thanks for listening.
Kia ora ahi, even though you're not here. Thank you for that. And Adeline, can I hand over to you to field any questions that you want to start with? You're very quiet.
Sorry. Oh, my microphone was off. All right. Yeah, I'd be happy to take over from here and address some of the questions that have been coming up. Feel free to keep asking questions in the chat. We'll try to cover as much as we can and get to what we can. So someone mentioned something about the dosages. Now that is from our slide about the Health and Disability Commissioner's standards. That's right, number 7. So that's a legal right that's enshrined in law. Doctors, of course, have to do no harm, but they also have to do so within the framework of informed consent. So that means that in terms of dosages, referrals, and medications, that informed consent framework does still apply to that legally. We also had a comment saying that most GPs don't have the right information and education to inform people about what hormones do, and that's not really possible in a lot of 15-minute appointments. What we would say is that, you know, doctors should know how sex hormones work. It's pretty basic. It's involved in many parts of healthcare. We know that doctors don't have comprehensive information about every single part of healthcare that they're providing. In the case of other hormonal medications like menopause and medications and things like that, you know, a safety sheet is considered enough. A lot of the time, doctors aren't even getting that signed informed consent from their patients. That's something that's actually been in international studies identified as a systematic issue with menopause, is that people aren't even getting told what those hormones do, but those are still prescribed relatively routinely. And we would like to see hormones be treated similarly to other medications rather than having these extra psychiatric or psychological assessments. The thing is as well that if the GP doesn't know how hormones work and they're referring that person to someone whose expertise is in mental health, that's not going to help. That person isn't going to have more information about hormones, or how hormones are going to affect that person's body. That's not going to give them that information. What they need is to have someone who knows how sex hormones work prescribe those things to them. We're also really glad that in this presentation we could share our checklist and that we have a lot of other resources that help explain this stuff in a relatively simple way. The national guidelines as well, we know they're a little bit long, but it is relatively easy for a doctor to look at the section of that's about prescribing estrogen, and they can see some of that stuff. And then when they're taking that into account and following that informed consent process, that can be a process of discovering how those hormones are going to work. It's the same as prescribing most medications. You know, you're going to have a journey of discovering how that is going to affect your patient and how it's going to help them and how they might have to deal with some of the side effects of that and what kind of dosage is actually going to work for their specific body. That's always a process that involves the patient and the doctor both having input. So we got primary care supporting under 16s and issues and challenges in that space. What's great is that the national guidelines do actually talk about how that framework of informed consent applies as soon as someone turns 16. They have a right to that. And what we also know is that from those national guidelines as well, they refer to some of the research that's coming up around that, showing that under 16s, in some cases, this is necessary for them. If you do want to access that, that checklist that's on our website, genderminorities.com, there's a tab up the top that says health, and there's health information for patients and providers, and it should be on there. It's also cool to see the comments about older people also not wanting to take part in this process. We know for a lot of people that this idea of being psychologically assessed to see if you're actually the gender you say you are, that is something that has been putting people off from trying to access their healthcare for decades and decades and decades. You know, this goes back to very early, as we said in the presentation. And that combines with things like doctors think that if they're sometimes will think that if they're prescribing estrogen to an older patient, they need to keep them on the levels that will be appropriate for a menopausal cis woman, when that's not going to create the body changes that are actually needed. And it's often not going to have the psychological effects that are needed as well. And so what we would like to see is more of an approach where, you know, if a patient comes and says, I'm a woman and I don't have enough estrogen, that they're being treated as a woman who doesn't have enough estrogen to have a body that they're comfortable with and to feel okay. We'd like to see that to be being a relatively standard process.
I had a reflection, just in case, as people might want to pop more things in the checklist discussion or just in the chat generally. I was thinking, Ada, about the framing of transition goals as a way to, you know, move away from the idea that you're assessing somebody's gender, whether it's a mental health assessment, psychological assessment, or just the GP sitting there trying to work out how to support someone. And it just feels so helpful to me. Is there anything you want to add about the framing of transition goals as part of the informed consent process? Because I've seen that be so helpful.
Yeah, so the basis of that is that what you're looking at is what kind of changes this person wants to see from their healthcare, and you're looking at how that medication might possibly create those changes. So it's actually a really kind of basic way of looking at it. It's like, how does this person's body need to change, and does this medication do that? And in what ways might that not work, or might it work for them? We have another question about, in Southland, an endocrinologist won't see patient referrals without a psych evaluation. Yeah, we know that's the case across a lot of the country at the moment, that people are still insisting on psychiatric evaluations. Ways around that, we do know that it's perfectly legal for all doctors to prescribe medication. So if a GP is prescribing, you know, they can do that. But again, we do need them to have the kind of knowledge that we're trying to share, so that they can understand how those sex hormones are going to affect someone and how they can help them meet those transition goals.
Yeah, and the transition goals being linked to how you feel. I feel like, you know, it's about you're inhabiting your own body and narrating your own experience and being taken seriously in terms of what you've noticed the effects are and what the effects are that you might want. And obviously, early on, you need to be made very, very aware of the limitations and the risks and the things that are inevitable and going to happen, and you can't pick and choose from hormone treatment. But I love to see the shift away from analyzing somebody's identity, which doesn't seem relevant at all, into this is a medical treatment and we can do a process that looks like providing healthcare. That's the way I'd love to see it continue to go.
So we have a question about the endometriosis guidelines. I'm not sure how exactly that plays out, but in general, one thing that we're all about is that, you know, people should be able to make their own decisions. They should be informed about what hormones are going to do to their bodies, and they should be able to consent to that. And they, you know, the patient should be able to decide whether they want to grow breasts or not. You know, that has to be their decision. That we can't be making people have hormone treatments before they are given other types of care if they don't want those hormone treatments. I would welcome you to email us at contact@genderminorities.com. In terms of GPs who have unconscious bias or they're transphobic about this kind of thing, we do know one legal framework that applies, which is in terms of providing reproductive health. If a doctor does have an objection to that on the grounds of religion or something like that, they have to make a referral to a doctor who will provide that type of care. And we know that that is usually used around other types of reproductive health care, but we don't see it so often used around sex hormones. And I think there's a lack of knowledge that that even exists. And we'd like to see more doctors aware that that actually is their responsibility. If they have some kind of ethical objection to someone being transgender, that they still have to refer that person to get healthcare. We do know, however, that there are a huge number of transgender people experiencing, they go to a doctor and the doctor says to them, no, you're not trans, you're just psychotic, or the doctor says, you're not trans and you should try not to be. And there are lots of different ways that that gets framed. We know there's a huge percentage of trans people who are experiencing that, and that is conversion practices. We're not sure how that's going to play out under that new law change, though. We would like to see some, more information about what the expected standard of respect for trans people is going to be for practicing doctors, but that's an ongoing issue.
My hope is that conversations like this with organisations like Gender Minorities Aotearoa and our next webinar with PATHA and the one after that with Counting Ourselves, that these are part of trying to ensure that anyone who would be a champion or an ally or a clinician or a doctor who is going to talk to your peers and try and say, hey, I attended this webinar and it had some useful resources and I can share them with you, or, the general peer-to-peer education and process of advocating is a really necessary part of upskilling the workforce, because we know that, of course, people, when they have a particular role, they respond well to other people who are in that particular clinical role, telling them or sharing information about what that role could do better. That's a comfortable place for people to learn. So if you are attending this webinar and you are aware that you have colleagues who you may not even know super well, or people who you've heard of who are not doing great practice, any kind of, it doesn't have to be, I don't mean you should go and have a massive intervention on them if you are a conflict averse person, but anything you can do to support the raising the professional standards and saying that's actually not really okay, here's some information, that's really helpful, because otherwise we are doing that all day, every day in a variety of different contexts. And it's, that's a big burden for community members, and it's something that some of us are paid to do and it is our jobs, but it's also what people are being kind of forced into doing for their own life and their own treatment process, and that's not ideal.
So we've just had another question. Someone's asking about normal screening, and I don't know what that means. You do mention that your computer doesn't allow you to record gender separately, and you should record someone's gender as what their gender is in your system wherever possible.
I wonder if, to hop in there, I wonder if what they might be meaning is screening for specific cancers like prostate cancer and that kind of thing.
Yeah,
I know
right.
that there is an issue with medical systems where if it can't be recorded what types of screening people might need, or what kinds of body parts they might have separately from their gender.
In general, that shouldn't be recommended by someone's gender at birth, because gender at birth is usually based on observation of that person's genital size when they were born, and that doesn't really cover whether they have a cervix or whether they have breasts or anything like that. And if you do end up doing it by screening by someone's assigned gender at birth, you're going to end up with things like a trans woman who's taken estrogen and developed breasts isn't going to get those breast cancer screenings if you're treating her like a man, but she's also going to need prostate cancer screenings. So the fact is that those computer systems that can't account for that simply aren't adequate for transgender people. And it's just one of the ways in which trans people are currently discriminated against. We need those systems to change.
Yeah, and being able to say when a system isn't working is a good, transparent thing to be able to do as a clinician. If you can't currently make your system different, then be really clear that that this isn't okay, and then do what you can to emphasize that you're responding to the health needs of the person in front of you, and you want to record everything as accurately as possible for them. We do understand that the system isn't perfect because we've all been through it, and we know it sucks. And we know it sucks for the people providing healthcare with a broken system as well as receiving it. So just as much as possible, I would recommend when something doesn't work, take a two-pronged approach of advocating for it to improve in whatever way that you can, and be clear and transparent about when it isn't right. That's a respectful thing to do.
In general, transgender people are very happy to have the issues explained to them. Obviously, a lot of the time we're going to get upset if the system doesn't account for us, but we're not. It turns out one of the main conclusions of our presentation, we're not crazy. We are regular people, and we're able to figure out what our healthcare needs are going to be if we're informed about that.
I'm assuming if people are sitting there quietly, oh, yep, something's come in, I'll be quiet again.
Sorry, I don't have any organizations to name off the top of my head. I know there's one Pride organization down south that is doing some healthcare work. A lot of the time, that's not the primary thing that Pride organizations are doing. And it's more the domain of the transgender health organizations like us, but we do work with a lot of the different Pride organizations to achieve that. There's something else I wanted to mention that's a bit tangential to the endometriosis, the case of people being told they have to take some kind of hormones before they can get a referral. One thing we have heard of happening with intersex people in this country is that they're getting told by doctors, these are the right hormones for you. They're not getting told what those hormones are going to do to their body, but they're getting told you have to take these or you'll face serious health risks. And a lot of the time that's being prescribed without those doctors actually having a good knowledge of what those hormones are going to do to that person's body. And that person, because they're not informed about what that does, they can't then come back to the doctors and say, hey, this is actually not working for me. They don't even have that option. And so we know that there's really disparities in the way that hormones are given to different types of people in this country. And one of the main issues is that they're not provided the same way that other medications are. They're not following a standard informed consent process. Just thank everyone for your questions. It's been really cool. And thanks for coming along to attend our presentation. There's heaps more information on the website associated with these webinars, and also on our own website, genderminorities.com.
Thanks, Adeline. It's really, really great to have you here. And again, thanks to yourself and Ahi for putting together that presentation for us. And I know people are asking about what's available from this. And yes, the recording will be available of the webinar for public dissemination, that it's not something that will only be available to people who've registered. But it might take us a minute to we're going to put subtitles on it and do things like that before we put it up on our Te Ngākau Kahukura page for these webinars. But there's so many important pages on the Gender Minorities Aotearoa website, which I know some people are already saying in the chat, they recommend it all the time and they use it all the time. That's definitely our experience too. It's really important to me that we keep having these conversations. Obviously, we've got a long way to go. I mean, I would like to think that things have changed and improved in some ways in the last 5 to 10 years. And I think we still clearly have a lot more that we could be doing better in a understanding that trans people are not a specialist area of knowledge in terms of most of these things. We need to be able to access primary care for all of our general healthcare needs, as well as potentially access to gender affirming care. So it's heartening that so many people who work in primary care are attending this webinar, and that you've probably signed up for the next couple of webinars as well. I know that a lot of people who've registered for this one have also registered for the next 2. If you haven't, please go ahead and do that, or please encourage your colleagues or other people to sign up as well. The next 2 webinars will have a slightly different flavour, with different organisations represented and slightly different topics focused on, but it is always part of this ongoing conversation about improving health outcomes for trans and non-binary people and improving health services, which I genuinely believe it makes it so much easier for the healthcare providers if we have good, clear information and a clear understanding of what is at stake, like what trans and non-binary people need and are looking for, and what we, I was going to say what we deserve, but what we deserve as does anybody else, you know, that this fits into a whole lot of existing frameworks that we already know about. So yeah, I really appreciate everyone being willing to be part of this conversation, and I hope that we can continue moving forward. I know Adeline has said you can contact Gender Minorities. You're also welcome to contact Te Ngākau Kahukura with follow-up questions. Yeah, this is really a moving and evolving landscape of trans and non-binary health. Kia ora koutou. If there's no other pressing questions that people are putting in the chat, we've got our last few minutes for Moira to close the space for us. Ada, is there anything else you wanted to add?
I thought I'd just thank you for having us on to present today.
It's been great.
Yeah, if anyone does have more questions, email us. Thank you.
Cool.
Kia ora. I'll now just pop this slide up, which is a link to where you can find more information on our website, though I noticed that Jono had a link in the chat as well, if you want to click through from there. And just thanks from me as well for giving us your time, and for all of the great conversation in the chat, and for your attention. And I'll just close us as we started off with karakia. So me karakia tātou, unuhia, unuhia, unuhia ki te uru tapunui, kia wātia, kia mama, te ngākau, te tinana, te wairua i te ara takata. Koiara e rongo whakaere ake ki runga kia tina, hui e tae ki e. Kia ora. Thank you.